Moving on to obstetrics. Obstetrics involves all of the anatomy we've previously discussed, but it relates solely to the process of pregnancy and birth. Know that most often, the process of birth requires little medical intervention. However, there are occasionally complications present, and they are hopefully discovered before the event of childbirth. In the event of a medical emergency, however, it is imperative that the surgical technologist think and act quickly, for the life of the mother and/or the life of the baby will depend on it. These emergencies can occur during labor, during birth, and even in the early postpartum hours. So at no time are we ever not paying attention. You will remember from a previous video that a fertilized ovum implants into the endometrium layer of the uterus. The placenta is an organ that adheres to the endometrium layer of the uterus during pregnancy. Nutrients pass from the mother to the fetus during development through the placenta. Your Prep U assignment this time around includes both female and male reproductive systems. Although this assignment is not due until during our genitourinary unit, I urge you to complete all the items pertaining to female reproduction now, because it is very beneficial to you. On the side nearer to the growing baby, the umbilical cord attaches to the baby and provides blood circulation while in utero. Knowing average gestation for humans is important when faced with patients who do not reach term, or those that surpass it, and the complications it could present. A normal delivery occurs vaginally without medical intervention. The cervix responds to the presence of the baby's head and through uterine contractions by dilating and effacing, thereby allowing the baby to be born. Occasionally, the delivering physician may perform an episiotomy, which is an incision into the perineum to help prevent tearing of the tissue during delivery. Depending on the grade of the episiotomy, it may need to be repaired immediately after birth by the physician. The scrub tech may be required to pass instruments to the physician during this phase of the delivery. Know that obstetrical complications can occur at any time. This is why the healthcare team is always prepared for anything. These complications can be purely obstetrical or could be surgical complications. We will cover 7 complications that range from common to rare in our typical patient population. First is placental abruption. This is a complication where the placenta detaches from the uterine wall prior to the delivery of the baby. This can occur after 20 weeks gestation and is categorized as partial or complete. In the event that a complete placental abruption has occurred, the life of the fetus is compromised, and depending on gestation, an emergency cesarean section will be performed. Placenta previa is diagnosed if the placenta implants itself partially or completely over the internal cervical os. Complications arise if the mother begins laboring and the placenta separates when the cervix begins to dilate and efface. This can result in life-threatening hemorrhaging. Often, this condition is diagnosed prior to delivery and can be avoided with a scheduled C-section prior to the mother beginning labor. Another fairly common obstetrical complication is pregnancy-induced hypertension, or high blood pressure. These cases can be mild or severe, and obviously it's the severe cases that we will concern ourselves with as it pertains to our role as an ST. In the event a mother is diagnosed with PIH and becomes eclamptic, they are at risk for seizures. Should this occur, the ST should anticipate an emergency C-section for the mother and baby's safety. A nuchal cord is when the umbilical cord is wrapped around the baby's neck at least once while in utero. It is rarely diagnosed because it is difficult to see on ultrasound. It is suspected if the heart rate of the baby drops significantly during a mother's contraction. In the event the baby's heart rate does not recover appropriately, or suspected delivery is hours away, a C-section may be necessary or anticipated by the scrub tech. Cord prolapse is diagnosed when, in the event the amniotic sac is ruptured, either naturally or artificially, and the umbilical cord travels through the cervical os and into the vagina and even out of the body. This can be life-threatening to the baby as the oxygen and blood supply come from the umbilical cord. Should a cord prolapse occur, an emergency C-section is imminent and time is of the essence. This particular condition hits me close to home. as I have a cousin who experienced this while pregnant with twins. She became eclamptic when she was 30 weeks along, and she was hospitalized. 30 weeks is too early to deliver twins, so she waited patiently as the days passed by slowly. At some point, the time is not known absolutely, her water broke. Because she was unaware of this event, she was not anticipating any major excitement for the day. Upon using her private restroom, she discovered one of the baby's umbilical cords had slipped through the cervix and had become strangulated. My cousin was rushed into surgery, and only one of the little girls survived. I don't tell you this story to make you sad, as the particular events in this story were completely unpredictable, but it is so important for you to know these conditions so that you don't have to look them up, and if one of them is discovered, so that you can react as soon as something happens in the event something is happening. Breech presentation is when the baby is positioned in the uterus any way but head down. This can potentially be a complication, as it can make the labor process longer and more difficult, which fatigues the mother and adds stress to the baby. Often, breech presentation is discovered in the final weeks leading up to the mother's due date, and there are techniques available that may reposition the fetus. Should a mother be scheduled for what is called a version, just like when you say, I have another version of the story. It's called a version, in which the OB physician attempts to rotate the fetus in the hospital through the belly, not surgically, but actually by palpating the abdomen through the skin and try to reposition that baby. It is common practice for an ST to be on standby, as there is a chance that the manipulation can stress the baby and a C-section may be required. Additionally, a C-section could be recommended to a mother laboring with a breech baby because the aforementioned reasons due to obstetrical emergency. Lack of progression is another common obstetrical complication in which the progress of labor stalls, or it is determined that the baby's presentation or head may not pass through the mother's pelvis. This situation is handled differently by each OB physician, but it is likely a C-section will be required, and in the event that labor has slowed, become ineffective, or in more extreme situations, the mother cannot effectively push the baby out. That's it. That's all the videos from me for this unit. So when you come to class on Thursday, we'll have some class discussion. We'll learn and handle the GYN instrumentation that we own, and you'll have time to work on your homework. So I'll see you then.